Your patient has ARDS, the PF ratio is tanking. You've cranked the PEEP on ACVC, you've paralyzed them, you've proned them, and the SATs are still 85%. What do? You open the lung and you keep it open. What is up, PEEP Squad? Welcome to Respiratory Roulette Masterclass, where you asked for a deep dive. So today we are covering APRV, Airway Pressure Release Ventilation. This is the mode that separates the button pushers from the clinicians. First, throw away what you know about inspiration and expiration ratios. APRV is an inverse ratio mode. Think of it simply as CPAP with a release. We hold the patient at a high pressure, P high, for a long time, T high. This pushes oxygen into the blood. Then for a split second, we drop the pressure to let CO2 escape and immediately boost them back up. It's like holding your breath underwater to stay buoyant and only exhaling a tiny bit to clear your lungs. There are 4 settings you need to master. First, P high. This is your recruiting pressure. It dictates oxygenation. We usually match this to the previous plateau pressure, typically 20 to 30 centimeters of water pressure. Second, T high. This is how long we hold that pressure. In APRV, this is huge, usually 4 to 6 seconds. This is 90% of the breath cycle. Third, P low. This is your release pressure. We almost always set this to 0. Yes, 0. Don't panic. I'll explain why in a minute. Fourth, T low. The dump time. This is tiny, 0.5 to 0.8 seconds. This controls ventilation or your CO2 removal. Now, why do we set P low to 0? Isn't that dangerous? Won't the lung collapse? Not if you time it right. This is the most critical part of the video, controlled auto PEEP. We set the time, T low, so short that the patient cannot empty their lungs completely. We open the door to let the CO2 out, but we slam it shut while there is still air rushing out. This traps gas in the alveoli. Even though the setting is 0, the actual pressure in the lung never hits 0. This is called the 75% rule. We cut off the flow when it's still 75% of peak flow. Here is the magic of APRV. Unlike other inverse ratio modes, the patient can breathe spontaneously at any time. They can breathe on top of the P high. This moves the diaphragm, which improves VQ matching to the dependent lung zones. It requires less sedation and no paralysis. A moving diaphragm is a happy diaphragm. Before you go pressing buttons, you need to know who this mode will kill. APRV is an open lung strategy. It relies on a quick release of gas. Therefore, it is contraindicated in patients with high airway resistance, like severe asthma or end-stage COPD. If their airways are tight, that 0.5 second release isn't long enough. You will cause massive air trapping and a pneumothorax. Also, be careful with head traumas. The high mean airway pressure can reduce venous return from the head, which increases intracranial pressure. If the ICP is high, APRV is usually a no-go. Okay, the patient is on the mode, but the blood gas comes back ugly. How do we fix it? Scenario A, the CO2 is too high. Do not increase a rate. There is no rate. You have 2 moves. First, increase the delta P, increase your P high. By making the drop from high to low bigger, you create more flow, which dumps more CO2. Second, lighten the sedation. Spontaneous breathing is the best way to wash out CO2 naturally. Scenario B, the oxygen is too low. Do not just crank the FiO2, you need recruitment. You can either increase P high to open more alveoli, or you can decrease T low. By shortening the release time, you trap more gas, creating more intrinsic PEEP and recruit the lung. How do we get off this ride? We use the drop and stretch method. As the lung heals, we drop the P high and stretch the T high. Eventually, you're essentially just on CPAP. APRV isn't magic and it's not for everyone. But for restrictive lung disease and ARDS, it's a powerhouse. That is the APRV Masterclass. File it away. Class dismissed.